Thank you, Vida. And thanks for inviting me to speak today. I suppose I've been working, as Vida said, since 2013, looking after I helped to roll out the implementation of the National Early Warning Score with my team there. And I suppose as a consequence, leading on from that, it made sense for me to continue with the Sepsis Implementation lead in 2015, I suppose, when we got the team together. There's a small typo there, but it was May 2013 when the news was rolled out. And the EWS committee in November 2015 got the communication from the HSE in terms of implementing the National Clinical Guideline for Sepsis Management, number 6. So we decided then to set up a subcommittee, a sepsis subcommittee, reporting back to the Early Warning Score Committee, because that's where it probably sits properly in terms of where it was to go from there on reporting structures, and the EWS report back to patient safety. So ultimately, because it's a patient safety tool, everything goes back to patient safety. So the Sepsis Subcommittee was set up, as I said, in December 2015, and the chairperson for that is our consultant microbiologist, Dr. Linda Fenlon. And Linda's a very practical and focused person and a real doer. So our membership then is very multidisciplinary, and it's also a crossover from the Early Warning Score Committee, because you do need that expertise when you're leading out on sepsis implementation, because it's triggered from the early warning score. So we've a very multidisciplinary membership in terms of ED staff, both consultant and clinical facilitators. We also have the infection control, we also have the microbiologists, we have pharmacy, we also have HYPE as well, and AIDON for sepsis, and also the AIDON for NPD, and myself. In terms of the first meeting then, we decided the membership, the reporting structure, which I've already said, the terms of reference, we kept it very focused and simple, adapting the HSE pathway for Vincent's, overseeing both the education and implementation of the sepsis pathway, and then also overseeing the audit of the implementation of that pathway. And we also discussed the national sepsis screening forms, and they were presented and reviewed, and it was very much a process over 2 months signing them off. And then we had the implementation plan and the education requirements as well. So looking at our sepsis screening tools, we have the standard tools that everybody has, obviously with just the slight input from Vincent's on it. And in terms of the fluids, we just changed the fluids and also changed critical care to intensive care, but otherwise the form is the same. On the back of the form, from a nursing input, we decided to put the ASBAR communication, because that's the standard communication tool we use in Vincent's. And basically it is just for the nurses to communicate between each other. And this form is actually filed in the clinical notes, but so any pertinent notes the nurses put into the standard nursing notes themselves. That's the ED form. Again, there was very slight changes. So the approval process we used was through the sepsis committee first. Everybody had to review the forms. Then we have a documentation working group in Vincent's, and all of our new forms go through that. Nursing executive and medical executive both received forms at the same time, and they were approved, and then finally signed off by our executive council. So March 2016 was when the forms were actually approved and came into play. Then in terms of looking at the implementation, very much we had to look at our implementation plan, and we looked at the national plan, and I suppose we looked at the national time frame, and everything had to marry in, or as much as possible, with the national time frame. So what we did was we put them both together and included updates in that. And so the sepsis committee was the same. We added an education piece in there for ourselves, just that we wouldn't forget anything. Obviously we commenced the implementation, and part of that, we had an audit process, a pre-implementation audit, and I will discuss that in a short while. And then we introduced the sepsis screening forms in the ED, AMU, and the 3 areas, medical, surgical ward, and oncology, haematology. So they were completed by the end of June. Obviously, the gap analyses were happening at the same time, the national ones with Ireland East. We continued the implementation. We actually finished our implementation on the 24th of August. I'm beginning to realise, though, having seen a lot of the presentations today, that my job is only beginning now. So there's an awful lot to do, obviously, but at least we've done the rollout. I don't know, in terms of percentage use of the sepsis form, I mean, obviously we have the analyses from the gap analyses with Ireland East and with Saline. But in terms of ourselves, I think we're going to have to do a lot more auditing ourselves, just to see what kind of percentage, and get out there and really make sure that the form is being used. Obviously, we had the compliance audits. We also did an IV trolley audit just to look at the sepsis requirements, and I will talk about that again. Our policies, we looked at the policy and decided, well, do we do a policy by itself or does it sit somewhere else? So we decided very much, because it reports back to early warning score, we put it into the early warning policy and put our definitions and any process and procedures in there. And we keep that in our QBOTS data management system. ED also have their own sepsis management. They had been using their own form initially, and now they've actually adapted the HSE form, and they're using that as well. And obviously they updated that, so they're on version 2 of their policy, and it's also kept in the QPulse data management system. In terms of education, we all know that education is key to the delivery of any project, especially a project in any hospital area. So communication with nursing management was key, because if we didn't have the support from nursing management, it was very hard then to roll it out and actually get buy-in from everybody around the house. And then obviously communication with the CNM in each area that we were specifically rolling it out in at a time. So up till the time that the e-learning programme was launched, we were obviously doing slide presentations. I'm sure you're all familiar with them around the country. So in 2016, all the previous areas that were audited originally were all presented, they had slide presentations delivering the education. So I was doing it on the wards. We're very lucky, we have very good clinical facilitators in ED, so they helped and did the education down in ED. And obviously AMU, clinical facilitator there, so we very much shared the burden there. And then all the wards, it's very hard in clinical areas because staff couldn't be released. So you have to go in and maybe do a few people at a time, or if they have a particular morning meeting, that you can get more staff. So in some areas we did that better than others. So then the e-learning programme, I suppose how we communicated that, well, we had emails, we developed A3 posters that we put around the house, laminated posters. We looked at the off-duty just to see what staff were there to train, how many staff we had to train in each area. I did a lot of cold calling because I didn't make appointments with staff. You know, you go to a ward and you decide whether the CNM has time to be approached or not, and very much it's on spec when you arrive. So that's what I did, and every week I was going around all of the wards. Also, I left an envelope on all of the wards because we were asking staff to print off their certs until I was able to get access to the HSE reports. So everybody was printing off their cert at the end, and it was being sent back to our department. I was also giving staff reminders all around the hospital. So every day I was going out in the wards, not only was I talking to the CNMs, I was going around to each staff member who was on duty and say, have you got your sepsis training done? If they had, if not, why? You know, can you try and get it done in the next 2 weeks maybe? So it's hard, it was very laborious really, but it did pay off. And then obviously when the implementation happened, we were giving refresher courses, because the time lapse between some people doing the e-learning and also actually implementation, there could have been 8 weeks. So just to refresh people's memory on what the sepsis form is, and also the EWS escalation piece as well. In terms of the student nurses, well, they're all trained in UCD. The new interns, we made COMPASS training and sepsis training mandatory this year. So up until last year, it was only the COMPASS training when they were coming to the hospital, and we made the sepsis training. So they all came with their certs for both, and that was really invaluable because they started going to some of the wards where the rollout hadn't happened to looking for sepsis screening forms. So it worked. And obviously we keep a database of all our training requirements in NPD. Now we're trying to do a cross-reference list at the moment with our own database and the HSE database. And obviously we get HSE land reports, and I've requested those on a monthly basis. So that was the poster we used. That was the communication tool that I emailed to everybody. We also emailed it out. Linda emailed it to all the consultants and NCHDs. And so basically we put it up every area wherever the CNM felt it was the most appropriate place, and a few places if they felt appropriate as well. So really it just mentioned, did you know that sepsis training is now in HSE land, just to reinforce that, why sepsis training was required, who required it, and how to access it. Some of the CNMs actually have WhatsApp groups for their wards, so they were actually able to send on the link for the HSE. So that worked well in a lot of wards as well. And also who it's approved by, and how many CEUs or CPDs people got out of that. And then we added a few things like the Sepsis 6, diagnosis of sepsis and time zero. And we also mentioned the policies and where people could get them. And the implementation poster, so we didn't want anything that was too wordy, but we thought maybe if we put the Sepsis 6 on a poster out there in bright yellow, and just the take 3, give 3, that we felt it might actually have more of an impact than something that was a bit more wordy and had too much information on it. So actually, I think it worked quite well, but I think the e-learning program, it really supported that, because people really thought the patient scenario was very, very good, and that it actually reinforced an awful lot of the Sepsis 6 and the whole need for it. And they could actually put it into practice and see it being put into practice by watching the HSE Land patient scenario. That's just the database that we set up in Microsoft Excel. So it's just the name, grade, department and date, and obviously it's facilitated by HSE Land. The HSE Land training numbers, looking from June to August, we started off, the first lot is the doctors, so we have that up to 45 at the moment, and that's mostly the interns. A few more have to do their training. The nurses went from 380 up to 480 approximately in August. So we have a lot of staff trained, and we're aiming by the end of September to have all nursing staff trained on HSE Land. So there's a real push, and all the CNMs are really pushing it now. But all the CNMs have actually been trained now, so I think it's easier when they have trained themselves to push it. And then obviously the total, we have 529 staff in total, including doctors, trained to date on HSE Land. We did some audits to support the implementation process. So the first audit we did was pre-implementation audit. I suppose we were looking at the 3 areas, like the surgical ward, medical ward, and oncology, haematology. And when we looked at those, we thought, well, wouldn't it be nice to know what our current screening practice is before we actually roll out the sepsis implementation form. So we got 2 fifth-year med students to help out with that over 3 wards. So we had 3 20-bedded wards were reviewed, and the audit performer was submitted and approved through clinical audit. We carried out the audit and asked 4 simple questions of each chart. Was the patient reviewed with an EWS of 4 or greater? Was the sepsis 6 followed? Were the SIRS criteria met, and was a diagnosis of sepsis made? So just keep it simple, and it's a yes or no answer. The findings were collated and reported to clinical audit. So what were the findings? Well, 60 patient healthcare records, as I said, were reviewed on 3 wards. 13 were identified as meeting the audit criteria. Now, 100% of patients were escalated and reviewed, so that was a relief. However, some of the other information was not so good. 69% of patients showed evidence of the sepsis 6 applied. So a diagnosis was made in 38.5% of cases, but you have to question the 30.5 that weren't. So is that because a diagnosis of sepsis was not documented, or were the SIRS criteria not applied from the start at all, or did patients not have sepsis? So we're not very clear on that, but then hopefully if everybody's using the form, that's going to be a lot clearer from now on. 3 cases should have had sepsis 6 applied, but did not. So that was very clear that not everybody was adequately screened for sepsis. Not always clear if sepsis was considered. So I suppose that is the issue, is that patients are not always being considered as to whether they have sepsis or not, and that is the big issue. So I suppose if we can get people to screen from the very beginning, and if we can get all of the nurses to actively fill out the forms and present them to the doctors if they think there's a suspicion of infection and the patient is triggering, then that they hand the form to the doctor when they come up. So I think that is probably the key thing, and that's the area we're working on. The recommendations, the main recommendations out of that report were implementation of the sepsis screening tool, and that was recommended, and then re-audit post-implementation, and we'll do that before the year end. Another audit we did, I suppose we had to look at what sepsis requirements we had available in terms of consumables available and easily available to doctors when they came to screen patients. So we looked at an audit of the sepsis requirements on IV trolleys on all wards. So our IV trolleys are used for venipuncture and cannulation, and we looked at ED separately, and ED has a dedicated sepsis trolley. So then looking at the main audit of 21 inpatient wards, the findings were that all wards had venipuncture and cannulation requirements. 70% of wards had blood culture bottles available. The IV giving sets and fluids not available, and dressing sets and sterile gloves not available. And the recommendations out of that were to review the trolley layout with an addition of sepsis requirements, trolley checklist required with new layout documented, and pilot a new trolley layout on an individual award. So checklist and trolley layout, I suppose that was our new list that we collated, and the top 2 drawers would be cannulation, then venipuncture, then blood collection tubes, and sepsis on the bottom, because hopefully that's not required, and it's not required as much. And that's the trolley with the relabelling and documentation on it. Okay, so I suppose the lessons learned at the end of this, well, what worked well for us, I suppose, it was very much a team, a multidisciplinary team, and the EWS input and the crossover between EWS and the new sepsis team. Our chairperson, a key to delivery of this project is a chairperson who will get things done, and Linda, fortunately, is very much a person who will get that done. The aid-on for Ireland East, Céline has been a really good input, and she's been at all of our meetings in as much as she can, and that's been invaluable in terms of her support and input. Senior nursing management, I think that's key in terms of delivery of a project like this, is that you have support from key nursing management in the house before you actually go to launch something, because otherwise you don't have the credibility as much out there. So that is very key in terms of delivery. Early identification of an aid-on for sepsis in the hospital. We did have a few different aid-ons throughout the phase, and that's obviously something that we could have done better, but some of it wasn't preventable in terms of somebody moving to a different role and somebody else leaving the organisation. So the most recent aid-on for sepsis that we have in the hospital is very much a doer, and she has really helped in terms of delivering the rest of the education. Communication, positive staff, after they've done the training, staff have really been positive afterwards in terms of the patient scenario that they did with the training, the e-training. Certainly helped them an awful lot, and I think it made it much more real for them and measurable. Mandatory training for the interns, and also for a lot of the CPD programs we have mandatory training. The e-learning program itself, certainly after the slide delivery, it was much easier for me. I didn't have to go around and physically deliver it to staff. CNM leadership, I think taking leadership from the CNM, and if CNMs can be actively seen to do the training beforehand, then it's much easier for them to encourage their staff to do it and say, look, you must do this. CNM updates, gradually updating everybody, communication really, and full implementation now that we have achieved. And finally, what do we change in terms of our lessons learned? Well, I think at the moment I'm working 4 mornings a week, so you really do need a full-time person in terms of delivering a project like this. But, you know, we do the best we can, and we've good support in nursing practice development. The aid-on for sepsis, as I said, I think somebody who can be continuous there during that project. Early CNM training, I think probably what I would have done differently is maybe ask the CNMs to do the training initially at the very first, and give a time frame for that. Senior nursing management training, not everybody has been trained yet, but I think we must make sure that they do. An emphasis on documentation of sepsis, I think probably no more than anywhere else, and as you were talking about internationally even, that we need to improve on that, and the documentation, actually mentioning sepsis if the forms aren't there especially. And then reinforcement of EWS escalation. And that's it. Thank you.
Thank you very much, Sue. I think that just characterises the huge amount of work that needs to be done in delivering this type of quality improvement project. Are there any questions for the floor from Sue? We've a question here.
Just one of the issues was training, and for nurses it's all good for the interns, but we have NCHDs that are changing every 6 months. Have you any tips about how to get them to be trained?
Well, no, what we did was, in terms of the interns, they've all been trained, and that really has had a good effect actually since they've started. But for the SHOs and registrars, it's very much, I suppose, trying to empower them, and I know the communication was sent out to all the NCHDs in the hospital. So other than that, it's very hard, and it was presented at both medical and surgical grand rounds as well. But other than that, I don't really have a solution at the moment.
My own feeling is that it should be compulsory.
Well, I think it needs to be, it will be mandatory, will it?
It's mandatory for interns. We haven't managed to get agreement for from an acute hospitals at an acute hospitals level to have it been made mandatory, and that's because of concerns about backfilling. But what we do say is that hospitals and hospital groups have the opportunity to, within their own system, to make it mandatory. So, for example, the CELTA group decided to make the e-learning mandatory for all healthcare workers and are working away on that. And because of that, the largest percentage of healthcare professionals who've done the e-learning programme are from the CELTA group.
Well, yeah, I think that should be rolled out nationally.
Yeah. Hi, I'm Linda Fenlon, the person that Sue's being very kind about. And in fact, I just want to say really that Sue's the one who's done all the work and she's the real doer. And to have someone like Sue in the hospital has been fantastic. And you can see how much she's done even in her half-time time that she has. She's really been responsible for getting this rolled out in Vincent's. And I've just sat there and said, great. So what my role, I feel, has been, and just the last question, is getting the NCHDs trained. And it's been a real difficulty. And we had hoped that it would become nationally mandatory. But in the absence of that, we hope to make it mandatory within St. Vincent's. Didn't succeed for this year's intake, but we might get there by January, certainly hopefully by next July. So I think that's critical to the whole rollout, because I've come across cases myself where, even though, and not just in Vincent's, in other hospitals where, you've rolled out the whole programme and then you go and see a patient and clearly the right thing didn't get done. And I think that's very sad. And we are missing sepsis still, I have no doubt. So, keep it up. And yes, I hope it does become mandatory. And thanks a million to Sue, who's been truly wonderful. Thanks.
Sorry, Sue, this question here.
Just during the start from Sligo University Hospital, but just the whole term mandatory. You can make something mandatory, but a lot of people ignore the word mandatory, and they still won't attend training. And I'm wondering, does anybody have any ideas into, is there a carrot and a stick, or what happens if something has been made mandatory and NCHDs arrive in a hospital and haven't done their mandatory training, but they're still employable and they still are allowed to work? So, because obviously you couldn't not have them working, or we'll be closing hospital doors. So it's one thing saying we're making something mandatory and it's a nice word, but does it actually happen in real life? And if you don't have this training done, what can I tell my NCHDs in Sligo now, for instance, tomorrow morning? All of the interns have their training done, and that's wonderful. But the EWS will stipulate that an EWS of 3 requires an SHO to review your patient, not an intern. So all of the SHOs are reviewing patients, and I will tell them that sepsis training is HSC, and it's online now, and it's mandatory, and yet they're still walking around smiling and no sepsis training done.
In Vincent's, from 3 to 6 can be reviewed by an intern or SHO.
That's
So
your local policy, I
our
suppose.
local
We're still
policy,
using
yeah.
the national guideline, which would have said at the time it was SHO. But we're still talking about this mandatory. Is there anything, has anybody in the room any ideas about what you can do to them if they don't attend mandatory training?
Yeah.
Can you withhold funds?
This is an international problem. I mean, there's no doubt about it. It's extremely difficult. Guidelines are notorious for being produced, never read, and sat on shelves. What we can do is we can create a situation where there'll be a generational change. So we have sepsis education improved at the undergraduate, postgraduate, and at the intern level. So over time, by next year, the SHOs will have done the mandatory learning. So we can comfort ourselves with that. In terms of individual clinicians, it's extremely difficult. What I do say when I'm delivering talks, but once again, my audience is a voluntary audience because it's not mandatory to go to grand rounds, is that the guidelines are what you will be judged against if there is a case where it's being, the management is being reviewed. So, and you are expected to comply with the national guidelines. They're out there, they're in the public domain, and that's what you will be judged against. Other than that, there's very little that we can do at this time.
Hi, Linda McEntee from Connolly Hospital here in Dublin. Deirdre, just to answer your question, what we did in Connolly for our standard precautions and hand hygiene was that they weren't getting their parking permits until they produced their certificate, and it has worked. We've now got 100% compliance.
Lots of interest here, Sue.
Is it working? Hello, Gráinne Rohan from University Hospital Kerry. I'm the nurse sepsis lead, and as like everybody, we have awful difficulty with education sessions. So one of our consultants won't give a reference to his NCHDs that don't have hand hygiene and their sepsis e-learning done. It's very difficult to get them to come to class, especially NCHDs, and I know that because I do most of the education with them. But I do have some NCHDs on board with me who will deliver to them as well. So it's just a case of really getting it multidisciplinary, I think, is probably the way to go.
Yeah, I think that's a really good point. I think that we need to look for clinical leadership from our consultants and make them responsible for their team's sepsis education and try and work it that way.
My name is Teresa Marshall. I'm working in the Mercy Hospital, and just not the stick effect, but the carrot, and this is a very, very simple thing that we've already found that it actually really works, is at Grand Rounds, obviously do your sepsis training at Grand Rounds, but if you've missed Grand Rounds, then you're not going to get a cert. So we've made up our own cert, and doctors really love certs. They really do. So I put on more training afterwards, and I find that there's Regis coming looking for training because they haven't been and they want a cert. The cert is really important. So it's just a small thing.
Small but effective. Thank you, Sue.